So we've done the pulmonary dissection here. So the first step is going to be taking off that chest wall. But before you do that, you want to make sure to identify the different muscles so you're not just cutting through everything. So what we've done here is we've reflected our serratus anterior as well as our external oblique, which we'll talk about when we get to abdomen, and our rectus abdominis muscle, just so that we can see the ribs nicely and clear everything off. From the outside, you can also see some of those intercostal muscles. So remember, you have 3 intercostals. You have your external, your internal, and your innermost. And the easiest way to tell what's what is the fiber direction. So these out here, these are like your hands in your pockets. The fibers are coming in as if you have your hand in the pocket, and they're the outermost. So those are going to be your external. And then notice that these fibers are then going the opposite direction. So these are going to be the internal intercostals. And on this side, you can see that a lot of that external intercostal membrane is still kind of covering them on some spots. And on this side, we've removed it. So you can kind of see how both look. So just look for that fiber direction. Remember that the external intercostal isn't going to come all the way to the sternum. So what you're seeing here is already internal, even though you don't really see anything reflected off the top of that.
And when we think about the fiber direction of our intercostal muscles, you'll notice the hands in pockets direction of the externals. These are going to function primarily in inspiration to help elevate the ribs, whereas the internal intercostals here are going to function during expiration to depress the ribs.
So this is the anterior thoracic wall removed, and we're looking at the internal surface of it. So if we're looking at the internal surface, this would be the right side, this would be the left side. So one of the main things that you want to focus on in here would be the internal thoracic vessels. These are also called the internal mammary vessels. So right here we can see the internal thoracic artery, the corresponding veins, and same thing over here, this would be the artery, and then the corresponding veins. So these come off of the subclavian artery, and they'll come down and they'll give off the anterior intercostal arteries that supply intercostal spaces 1 through 6. And as it comes down, it's going to pass anterior to this muscle, which is your transverse thoracis muscle. So if we reflect that, then we should see the full artery. So it'll give off anterior intercostal arteries 1 through 6. Then when it gets to about the level of the intercostal space number 6, it'll split into your musculo-phrenic artery and your superior epigastric artery. So the one that stays more medial here, this is going to be your superior epigastric artery, and the one that stays a little bit more lateral is going to be your musculo-phrenic artery here. And that musculo-phrenic artery is going to give off anterior intercostal arteries 7, 8, and 9, supplying those spaces. So that's those, and you can see there are corresponding veins for each of those. But remember that the corresponding nerve, it's just the intercostal nerve. So the arteries and the veins are anterior intercostals, and then the nerve is just intercostal, which you can see over here. So these travel within the neurovascular bundle, also commonly called the van, because it runs vein, most superior, artery in the middle, and then nerve most inferior. And all 3 of those run in that costal groove on the inferior surface of the rib, which if we've talked about the chest tube insertion yet, that's why you would want to be inserting the chest tube along the superior border of the rib, because these are traveling along the inferior border of the rib in that costal groove. So we'll show you a picture of this so that you can see these a little bit better, but that is your intercostal bundle right there. Okay, so the other thing you want to notice on the internal view of this is you can see the innermost intercostal muscles. And remember that the fiber direction is going to be the same as the internal intercostal muscles. So again, these are going to help with expiration because those are going to help depress the ribs. So innermost intercostal. And remember that neurovascular bundle, that van, is going to travel in between the innermost and the internal intercostal muscles. So once you get that chest plate off, you can see the lungs sitting in their normal anatomic position here, and you can see the pleura.
So what we're showing you here is actually that costal part of the parietal pleura. So you'll remember that there are three different parts of the parietal pleura, the costal part being one of them, that is adhered to the deep surface of the thoracic wall and innervated by those intercostal nerves. The other two parts are called the mediastinal and diaphragmatic parts, and those will be innervated by the phrenic nerves that we're showing you here that course in between the heart and the lungs through the mediastinum towards the diaphragm. And another important spatial relationship to note is that these phrenic nerves pass anterior to the root of the lung where you find the bronchi and pulmonary vessels. So in order to remove the lungs from the body, what we're going to do is we're going to move our phrenic nerves out of our way and come down and try to, with our fingers and using blunt dissection, try to find the root of the lung, which is where all of the pulmonary vessels and your primary bronchi are going to be located. You're going to try to make, with your fingers, find the boundaries of that root, and you're going to cut through all of the structures in there to help free up your lung from the pulmonary vessels so that you can then remove the lungs from the thorax.
So ideally you want to be cutting close to the heart, so you want to be cutting pretty medially. That way when you get it out, you'll still be at the level of the primary bronchus and you'll be at the level of the arteries and veins without the branching, and that will really help you to tell what's what when you're looking at the hilum. So that's why it's important, as Jack was saying, to get your fingers around them and identify them. That way you can cut each individually nicely with scissors, so that then when you remove them, you'll have a nice looking hilum.
So here we're looking at a lateral view of the left lung that we just removed for you, and one of the first things that you'll want to appreciate is that the surface of this lung is going to be covered in a layer of visceral pleura that transitions from the parietal pleura at the hilum of the lung and is innervated by contributions from the vagus nerve and sympathetic trunk. So on our left lung here, we only have two lobes, a superior and an inferior, and those are going to be separated right through here by this oblique fissure. And part of the reason why the left lung only has two lobes is because we need to leave enough room for the heart to sit in the body. So looking at it right here, you can appreciate this little arch, which is called the cardiac notch. And then there's also a small indentation along the medial border of the left lung that's called the cardiac impression, which is where the left side chambers of the heart are going to sit relative to the lung. So now looking at the medial surface, we're going to pay particular attention to the hilum of our lung right here. So there's a couple structures that we're going to want to point out on the hilum, being the pulmonary artery. We have two pulmonary veins here and here, and then this thicker walled structure right here, which is going to be the primary bronchus that comes off of your trachea. So using the hilum is going to be one of the most useful ways to identify one lung from the other. So in order to differentiate the lungs, you're going to want to use the acronym RALS, or R-A-L-S, and that acronym is in place to describe the relationship of the pulmonary artery to the primary bronchus. So again, this is a left lung, so using our acronym, we're going to use the back end of it of RALS, which is LS. So the LS stands for left superior. So what that means is that we should expect to find our pulmonary artery here with the thinner wall superior to the primary bronchus, which has this thicker wall here. And we can tell that the artery is superior to the bronchus because we can see the apex of the lung, or where it comes to a point right up here. And we know that the apex is the superior portion of the lung. So then the last little structure that we want to look at on the left lung is down on this inferior portion of the superior lobe called the lingula. So now we're going to move you over to a lateral view of the right lung that we also just removed for you. And again, one of the first things that we'll want to appreciate about the lungs here is that they're covered in that layer of visceral pleura that had transitioned from the parietal pleura at the hilum of the lung and again is innervated by contributions from both the vagus nerves as well as the sympathetic trunk. So we wanted to show you these two different examples of a right lung, so we'll come to the more typical looking right lung over here and point out that there are 3 different lobes on the right lung as opposed to only 2 on the left. So here we have our superior lobe, as you can tell by the apex of the lung up here, have a middle lobe right here, and then all the way over here would be our inferior lobe. So again, because there are 3 lobes instead of 2, there are also 2 different fissures. So separating the inferior lobe from the other 2 lobes will be the oblique fissure that travels the whole way down the lung. And then separating the superior lobe from the middle lobe, we also have a horizontal fissure right through here. So when we were dissecting our cadaver to record this video for you, we actually noticed an interesting case with the right lung here. You'll notice that there are only 2 lobes on this right lung that we pulled out of the cadaver that we showed you earlier. So this is a good time to reiterate the point of using the hilar structures to determine the lungs from each other, because if you were looking at this just from the lateral view, you would not be able to appreciate that this is a right lung, because in this case it's a little bit of a variation in the anatomy where the right lung only has 2 lobes on this side. So in order to tell that this is a right lung, we're really going to need to rely on our hilar structures right here. So you'll remember the acronym we talked about earlier was right anterior left superior, or RALS, R-A-L-S. So because this is a right lung, what we should be looking for here is for the right anterior relationship, so that the artery should be found anterior to the primary bronchus. So looking down at the hilum here, we have our pulmonary artery right here, with pulmonary veins being up towards the top as well as down here. And then right through here with the thicker wall that you can see right here, this would be our bronchus. So right now I'm pointing you toward the anterior side of the lung. This would be the posterior side of the lung. So when we're looking at our bronchus, we notice that the artery with the thinner wall is actually anterior to the bronchus. So that's where the right anterior part of RALS comes from. So the only way that you would be able to distinguish this lung as being a right lung is by using this relationship of the hilar structures, as opposed to trying to count the lobes on the lateral surface of the lung. One other thing that we want to notice now that the lungs have been removed, you can see that we've done a slightly different level of dissection on either side of our thorax here. On this side, we've left the parietal pleura intact. So you can see this kind of membranous appearance on the back of the thorax over here, because that parietal pleura is still in place covering our posterior thoracic wall, which is different than what we have on this side, where you can clearly see the muscle fibers of your subcostalis muscles crossing multiple intercostal spaces. That's how you differentiate them from the intercostal muscles themselves.
So on here, all of that parietal pleura has been peeled off. So that's why you're seeing nice muscle fibers, and you're still seeing that on there. And then also in here, just to point these out, you can still see those pericardiacophenic vessels. So you can see one here, and then one here, and one there. Something else you can see, so we just pointed out those pericardiacophenic vessels, and then right next to that you can see your phrenic nerve on both sides. So the phrenic nerve, you can see it traveling just in front of that anterior scalene muscle. It comes through the thorax. Remember, it's going to be just anterior to that lung hilum, or in that root of the lung. And then it passes, and it's going to go directly to the diaphragm here, and it innervates the diaphragm. So we talked about how it innervates the parietal pleura, and then you can see it innervating the diaphragm here. Now when you first look at the diaphragm, it doesn't look very muscly, but actually on here, if we've peeled away some of this tissue, this pleura, now you can actually see muscle fibers on here. So this is going to kind of come down, and it's dome shaped, and you can see it's attaching to the inside of the thoracic wall here. So from a side view here, you can see where we've cut through the ribs, and you can see that phrenic nerve and the pericardiacophenic vessels from the side. So we wanted to show you the side view so you can appreciate that the phrenic nerve and those vessels are going to be anterior to that hilum. So the structures in the hilum of the lung, we've got our pulmonary artery here, pulmonary vein, other pulmonary vein, and then bronchus. So where all of those are cut, we'll see the corresponding surface on the lung, but notice that you've got your phrenic nerve and the pericardiacophenic vessels just anterior to that. And then if we follow the phrenic, you can see that it is in fact going to that diaphragm here.